Thank you so much to invite me to present a little bit of the work which we are doing in treating dizzy and vertigo patients across the world. It is indeed an honor for me to be speaking in an audience where my mentor, Professor Herman Kingma, is there. I'd like to talk about how technology is transforming vestibular science and how we are able to treat patients in different geographies in a better way. So I'd like to declare my conflict of interest as director and scientific advisor to NeuroEquilibirium. I work passionately in the field of development of equipment and protocols in the treatment and developing management protocols for vertigo and balance disorders. So here I'd like to talk about how, Sonia, I'd just like to just inform you that that 175 is now 300 clinics across 16 countries. So how remote diagnosis and treatment of vertigo and dizziness is helping us democratize the specialist care. So the traditional way of telemedicine is the patient is on a phone call or a video call with the doctor. And by introducing technology into this, through our deep tech remote diagnostic platform, the patients go to the local doctors in their own cities and the tests are performed there. But through a cloud-based platform, we are able to analyze these reports. The specialist doctor, who also has a team of doctors actually who have technology to assist them to enhance their capacity through expert systems, machine learning, uh, natural language processing, etc. So different technologies, and this allows us, sorry, to be able to analyze right from the history to the reports to patients all over the world. So we have a digital history taking module in which it's basically sort of like an algorithm based tree. And it's to ensure that we have a comprehensive information about our patients and also the clinicians, wherever they are, we have a uniform system to ensure that all the data points which we need are captured. So it's like if a person has hearing loss, it will then ask whether if it's right, left, progressive, or was it just suddenly on one day? Things like that. But if there is no hearing loss, that means no further questions would be asked. In this, we find out what is the onset, the progression of the disorder, the associated triggers or associated symptoms which the patient may be having along with their past history. We then move on to the diagnostic test, which gives us an idea of the functional status of the different parts of the balance system. Here I'd like to show you how we are also able to capture the different components of the nystagmus. So not just the horizontal and vertical components, but also the torsion, which is so important for our diagnosis for BPPV, especially of the vertical canals, the posterior canals. So with this, we are able to be able to analyze the videos and the graphs of these patients all over. So at the end of this, we have this kind of a you can see a concise history all in one page, and on the other one we have the reports of the test. These are then evaluated by a multidisciplinary team of neurologists and neurootologists. And with this, we are able to achieve a differential diagnosis of different kinds of causes of the dizziness, whether peripheral, central, and other systemic causes as well. So Benjamin Bell has said that AI will not replace doctors, but it will augment them, enabling physicians to practice better medicine with greater accuracy and increased efficiency. So here I'd like to talk about how there are different kinds of technologies which we have incorporated in basically being able to treat patients, different kinds of whatever they will be requiring, whether it is rehab to CBT to different kinds of treatment planning. So I'd like to start with the digital advancements in vestibular rehabilitation and how we are providing vestibular rehabilitation online to our patients so that geography or accessibility is not a limitation for these patients to undergo a customized rehab program. So we are also tracking the movement of the patients, how they are following the exercises. And with this, we're able to give a progressive and an adaptive according to the requirement. What is the site of lesion, the severity, the age, and other comorbidities, which will be deciding factors of what kind of programs they need. Also using virtual reality patients. Patients with acrophobia, fear of heights, we take them with our virtual reality goggles into different situations, starting with the less stimulatory ones, and gradually, as they get adapted to it, go higher and higher in the levels. So, vertigo and dizziness affects 15% of the population, but most patients can never reach a neurootologist. But through this cloud-based platform, we are trying to expand the reach of the specialist exponentially. So basically, we work on the hub and spoke model and how we can make certain centers of excellence and expertise to help the other areas which are not so well equipped with this. So this is what we have from Jaipur, from India today. But the future is that we can have many more centers, many more hubs, which will be able to provide specialist care to greater populations. Here, I'd like to talk about a lot of work which I've done with Herman and Raymond on new insights in the diagnostic and therapeutic maneuvers for BPPV. So BPPV, we all know, is a mechanical disorder. The crystal, the otolith debris from the utricle is dislodged into one of the semicircular canals. And the treatment involves bringing that displaced debris back into the utricle. But it's not as easy as it sounds because the labyrinth is like a three dimensional structure, and bringing the crystal back is like playing in a 3D maze. So we have to take the head to different positions, to different angulations to do it. There are several publications which describe how the different maneuvers are to be done, but just looking at a two-dimensional figure to be able to understand a three-dimensional problem is often difficult. So there are different kinds of you would see devices or what people have tried to devise to understand this better, but what we have worked on is simulations. So using the CT scans, the temporal bone, we've extracted the 3D anatomy of the labyrinth, and then we've aligned it with the virtual head. The next step was creating a humanoid to simulate the body and labyrinth movement. So by connecting it with the humanoid, you can see what happens when there is a change in the head movement. And by placing this crystal, what you see as the yellow ball, you can see how the crystal moves under the influence of gravity in different positions. And we all know the eyes are the window to the balance system. And by connecting these canals with their respective oculomotor muscles, what we could do was pair the eye movements, because that is what the clinician is actually seeing, deciding with the eye movements what is really happening inside the labyrinth. So here in this simulation, you can see you have the 3D labyrinth as the head moves and the patient goes to the head hanging position. Under the influence of gravity, the yellow crystal is moving through the canal, and that is resulting in a torsional upbeat nystagmus, very typical of the posterior canal BPPV. When the debris reaches the most dependent position, the nystagmus slows down and finally stops. So here you can see how it relates to a real world scenario. And this is what we've published, our paper on simulations in BPPV in the Frontiers in Neurology, along with Professor Kingma. Now here I'd like to show you if the crystal was in the horizontal canal, and if we do the Dix-Hallpike, you can see the nystagmus is horizontal, not the torsional upbeat nystagmus. But the other thing what you see is that a horizontal canal BPPV, the crystal has been displaced during this Dix-Hallpike test. And because of this, the lesson we have learned from the simulation is that the supine roll test should be performed as the first positional test before the Dix-Hallpike. I'm often asked that since posterior canal is the most common, why don't we just go for posterior canal testing? Why do we even need to do horizontal testing? And this was our paper, which we published along with Professor Omron from John Hopkins, Professor Edlow from Harvard Medical School, in which we studied almost 4,000 consecutive BPPV patients, all confirmed with the VNG findings. And what we saw was, yes, posterior canal is the most common at about over 48% patients, but horizontal canal is not too far behind at about 46. And that is why it's very important to test every patient for horizontal canal and posterior canal. Anterior canal, yes, is not so common. So here I'd like to show you some simulations of the supine roll test. So when we start with turning the head to the right side, we get right beat nystagmus in this patient of right horizontal canal. The patient is brought back to the center, and now on turning the head to the left side, you can see that the crystal moves further through the canal and you get a left beat nystagmus. So turning to the right, what you would see on the VNG, turning to the right resulted in a right beat nystagmus, and to the left, a left beat. So you have geotropic nystagmus, changing direction according to the side. But suppose I did the same patient starting from the left side. So if we started our positional test from the left side, the crystal would move through the canal. We get left beat nystagmus. But here you see that the debris has been repositioned out of the canal. And now when we do our further positional test, turning to the other side, as the crystal has already been replaced, we will not get any nystagmus. So this Simulation tells us that when we start from the same side, from the right side, we get direction changing nystagmus. But if the same patient we had started from the left, we would get nystagmus only on one side. And this tells us that the sequence with which we test affects the outcome of the test. So the positional tests have an observer effect, and the test itself may result in resolution of BPPV. So, this was our publication in Frontiers in Neurology, where we talked about the modified interpretations, how the sequence of testing would affect the final results of our tests. And according to that, just another publication which we did was on a standardized protocol for BPPV testing, which means that we start with the supine rope test, start with the right and then the left, and then you go on to the Dix-Hallpike, right and left, and finally go to the deep head hanging test. The next step, I'd like to talk about how the simulations helped us in making BPPV treatment more efficient. So I like to show this through the Simon maneuver. Now, sometimes people are not doing the correct angulation, or sometimes they even use a pillow for the Simon maneuver. So, by doing an incorrect angulation, what I'd like to show you is that when we swing the patient to the opposite side in our maneuver, the crystal may fall back to the same side. So that means it is a failed maneuver. By turning the head by 45 degrees and going to the side lying position, what is happening is that the crystal moves through the canal, and then we have to wait till the nystagmus subsides. And then in the next step, we swing the patient by 180 degrees to the other side. And this allows the crystal to cross across the other arm into the crus commune and out of the canal. So with the simulation, we then studied the Simon plus maneuver, which means that after turning the head by 45 degrees, we add another 30 degrees to the side lying position. And the benefit which we saw with adding these 30 degrees was that the crystal crosses the curvature of the posterior canal. And now, when the patient is taken to the opposite side, you'll see that it's already crossed over, so the chances of failure or fall back to the ampullary end is much less. So Simon Plus helps in increasing the efficiency of the maneuver. And this is similarly what we studied the Yakovino maneuver for anterior canal BPPV. So in this, the patient is taken to the deep head hanging position as the first step of the Yakovino maneuver. Here you see the crystal in the anterior canal, and you can see the movement of the crystal going through it to the dependent position. In the Yakovino maneuver, the second step is going to the chin to chest. You're flexing the neck of the patient. And when we studied the simulation, we saw that there was a chance of the crystal moving into the posterior canal, what we call canal switch. In fact, in the criteria, in the classification of anterior canal BPPV, it is said that one of the factors to a certain the certain anterior canal BPPV is canal conversion to typical posterior canal. But that means you would need another maneuver to treat this. So what we came up with was the modified Iacovillo maneuver, in which we do the deep head hanging position. The patient is taken straight down by 30 degrees, but we skip that step of chin to chest, and instead we bring the patient back to the sitting position. And what we saw was, by doing this, the debris moved straight into the crus commune. It would not go into the posterior canal. So by simplifying the maneuver, we prevented the risk of canal switch and made it easier for the clinician. And this is what we published in our paper on anterior canal BPPV maneuvers. Now, the goal of the repositioning maneuvers is to take the affected canal into planes which allow the displaced crystals to move out of the canal and back into the utricle. So here we see, we all know the Epley maneuver, how the different steps are required, the different angulations, 45 degrees, 30 degrees down, then turning in the next step by another 90 degrees. It's also important to wait at each step for the crystal to reach the most dependent position. If we move before that happens, there may not be a complete movement, and the crystal may fall back to the previous position. So you can see that different angulations are required. So we all know that the Epley is like a gold standard for posterior canal, but the ground reality is that less than 10% of doctors actually perform these maneuvers. And when we studied why is it, what literature tells us is that they often have difficulty in remembering which maneuver is required for which canal and what are the steps of each maneuver. So for this, we've developed a BPPV guidance system, which is a tool to optimize the maneuver performance. So the guidance system involves a headband on which has sensors to ensure the angulation and the plane, which can actually detect these things. So and we connected this with the screen. So you have a humanoid on the screen which tells you what is the position which is required, and it is connected in real time. You're actually able to see what is the angulation of the patient, what you are doing. So here, the yellow is what is the patient's head, and the blue is what is required. So once they both meet, the green light turns up. And with this, the clinicians are able to ensure that they are reaching the correct position at each step. So the screen is also telling them what is required in each step. And so by meeting that, and when the head meets the same position, we get the green light. This makes sure that each step of the maneuver is done in a correct way. We studied this in which using healthy volunteers to perform the Epley, we did it with the headband in position but without giving them a visual feedback. How what was the angle, the variability in the angulations and head position? So you can see the one on the left is without the guidance system, and when the clinicians received feedback, the visual feedback from the guidance system, you could see how it reduced the variability. In fact, we saw, this is what we published, that by giving this visual feedback, we could improve the outcomes. And in fact, it reduced the variability by over 6%, 6 times. So I'd like to just conclude with how technology, by harnessing technology, we can give better treatment to our patients. This is my book on BPPV. It's a ebook in which it has all of these simulations, the VNG videos, etc. So thank you so much, and I'd be happy to answer any questions as well.